Good afternoon. Welcome, everyone. So glad you're here with us today for this Health for a Change webinar. Again, my name is Rochelle Seeger. I'm the Community Health Research Officer here at the Foundation for a Healthy Kentucky. And the Foundation is a nonprofit philanthropic organization created in 2001. And our works mostly around meeting our mission, which is to address the unmet health needs of Kentuckians. The Foundation does this by developing and influencing policy, improving access to care, reducing health risks and disparities, and promoting health equity. And I'm honored to be working here at the Foundation on that effort. As part of those efforts, I coordinate and schedule these Health for a Change training series. The Health for a Change was conceived in 2011 to meet people just like you, health leaders, people in nonprofits who are working to improve the health of Kentuckians. This Health for a Change training series is a capacity building, so we do things like have this webinar on Kentucky ACEs, we've had grant writing workshops, and we have different topics that are all archived on our Health for a Change website that you see right there at the top of our website page. So a reminder to everyone that this webinar is being recorded, and you'll have access to the slide deck in the next day or two. I'll give you an email notification so everyone will have access to the full slide decks from our presenters today. Before we get started, I just wanted to let you know about some great upcoming events in the Health for a Change training series. I'm thrilled to have a webinar on evaluation on August 8th. We call that Planning for Success. Also, there'll be a workshop, so all those people on our call in the Bowling Green area, please join us on August 16th where we'll have an in-person workshop in Bowling Green, Kentucky called Working with the Media. We have a webinar on August 22nd where Lynn Quincy and Ben Summers from Harvard will be talking about low-income Kentuckians and their health care access. That'll be via webinar. September 27th in Northern Kentucky, we'll have a Smoke-Free Campaigns in-person workshop. I'm thrilled to sponsor that in partnership with another health foundation, Interact for Health. And finally, today, October 24th, we'll have another Working with the Media workshop in Paducah, Kentucky. So I know we have people on the call from all over Kentucky, so I will be thrilled if you join us for those upcoming free events. My final announcement before we turn it over to our great speakers this morning, the Foundation's annual Howard L. Bose Memorial Health Policy Forum will be held in Lexington this September on Monday the 24th. Registration spots for that are filling quickly, so if you're interested in Kentucky's substance use epidemic, please join us on that date. The registration is now open at regonline.com/Bose2018. I'm thrilled to turn it over to David Fink, who works on the Bounce Coalition. This is really exciting. We have two great speakers to talk and learn more about ACEs this morning. And I want to turn it over first to David. Welcome, David.
Thank you very much. And as Rochelle said, my name is Dr. David Fink. I'm a licensed psychologist and co-chair of the Bounce Coalition, and I'll talk about the Bounce Coalition in a moment. I'm also a vice president of residential services at Uspiritus, which is an organization in Kentucky that has residential facilities as well as outpatient facilities for youth and their families in need of behavioral health services. This particular webinar is really focused on my aspect of reviewing the impact of adverse childhood experiences for the audience, talking about the ACEs study. We have developed some programming for educational services as well as other agencies that provide services to youth. And today we're going to talk more specifically about how to explore some of the trauma-informed programming for schools. We're going to identify ways that we have measured the impact and sort of envision a roadmap towards creating and implementing a trauma-informed environment. Briefly, let me just mention what the Bounce Coalition is. That the Bounce Coalition formed in 2013. It's a multi-agency effort. There's about 17 agencies that participate in the Bounce Coalition, and it was initiated through a grant through the Foundation for a Healthy Kentucky. They're Investing the Future of Kentucky grant. And what we did was we, as consistent with the RFP for this grant, we looked at data in our area, and the goal was to find one health outcome that we wanted to improve in our area's youth. And after a year of looking through data and looking at different aspects, what we decided to choose from was trauma and building resiliency. And we'll talk about why that is as we get into talking about the ACEs study, because the ACEs study is really the cornerstone of this programming. So let me talk briefly about the ACEs study. ACEs stands for Adverse Childhood Experiences, and the story behind this study I think is worth talking about. It really begins almost like many discoveries as in part by accident. There was a physician on the West Coast who was treating individuals in his practice, many of whom were employed and had private insurance, and he was treating them primarily for obesity and finding that with the treatment for obesity they would lose weight, but the weight would come back. He then began to do some research that was also picked up by the Center for Disease Control. And in the process of this, what they found were that if you looked at an individual's childhood experiences, you could identify risk factors for health outcomes as adults. And there are a few really important aspects to this. One is that these childhood experiences were reported by the adults themselves. So it wasn't some outside observer saying this is defined as an adverse childhood experience. It was what the subject defined as an adverse childhood experience. And it really is divided up for the study into three different areas. You have the areas of abuse, which involve physical abuse, emotional abuse, and sexual abuse. Then you have neglect, which looks at physical and emotional neglect, and then household dysfunction. So was there mental illness in the family? Is there an incarcerated relative? Was there substance abuse, divorce? And then domestic violence is another factor. And what you find when you look at health outcomes, and this is a diagram produced by the Robert Wood Johnson Foundation, is that there are certain behavioral and physical health outcomes that really most people would expect. The lack of physical activity as adults, smoking, alcoholism, drug use, missed work days, those are all behaviors that when you think about having more traumatic experiences or adverse childhood experiences as a youth, it doesn't surprise most people to know that these behaviors fit with an increased prevalence of the adverse childhood experiences. But what you also find are some health outcomes that really are initially a little bit surprising. And you have things like obesity, diabetes, depression, suicide attempts, broken bones, heart disease, lung disease, cancer. Really all of your serious physical health issues become related to adverse childhood experiences. And there seems to be a loading factor, which is that the more experiences you have, the risk seems to increase. So that if you have 4 or more experiences, then that leaves you much more susceptible to the poor health outcomes. So that is one aspect of the study that I think is important for everyone to be thinking about. The other aspect of it is the overall prevalence. And I think it's important to recognize that the 17,000 participants in the study, that 2/3 of the participants in the study report at least one adverse childhood experience. So I would like everyone to be thinking about that as we talk about trauma-informed care and resiliency building, because what that reminds us all is that while 4 or more ACEs seems to be an important factor for increasing the risk of health, disease, and poor behavioral outcomes, that even one incident is pretty common, pretty prevalent among all of us. And this, I will point out that just briefly, if you look at this, these diagrams here, what's important I think to note is that even when you have something that only occurs in 4.7% of the population, like an incarcerated relative, it clearly has a meaningful impact on outcomes for health disease. So overall, what I want the audience to be thinking about is that the ACEs study is one of the largest studies ever done. in health and social effects of adverse childhood experiences, and it has incredibly compelling information from an epidemiological perspective about explaining that childhood trauma that is untreated, unmitigated, has a long-term effect and damaging consequences on physical and mental health. And again, that the more categories of trauma that are experienced, the greater the likelihood that the individual is going to experience health and other problems. So what I'd like to do now, having sort of introduced very briefly the ACEs study, is that I'm now going to turn the conversation over to Dr. White, who's going to talk a little bit about the specifics of Kentucky's data and how that relates to what we have with the ACEs study, and then we'll bring it back to the Bounce Coalition and to trauma-informed and resiliency building schools. Dr. White, to you.
Well, thank you. I appreciate your introduction. I'm at the Kentucky Department for Public Health, and as you can see from the slide, I have experience in OBGYN. I practiced for 20 years in clinical medicine and then came to the Department for Public Health. So the next slide is, I love to start my presentation about ACEs with the 3 babies. I usually get feedback from people about what they think, and since this is a webinar, I can't get that feedback. But if we'll look at the next slide with the picture, I usually get audiences saying things to me. And Rochelle, I need you to change that because I don't have the controls. There we go. Okay, great. So usually the responses I get, people will say, this looks like innocence, this is precious, this is sweet, this is interactive. Those babies have not had all of the adverse childhood experiences they're going to have before they're 18 years old. What happens between that innocence that we see there and what happens later? So next we're going to talk about the critical periods that are part of that baby's life, and that's 0 to 2 years. That's that critical window when the brain gets hardwired. And this is one of my favorite pictures of send and receive. The mother sends a message, the baby coos back. And while that's happening, the brain is continuing to make connections like building a house. And if there's a weak foundation in that first 2 years, you're not going to have a very strong house. The first 3 years of life, the baby grows about 700 new connections in the brain a second. That's 700 a second. So without that secure attachment and that nurturing relationship, if you don't have those connections, then you're going to have problems as that child gets bigger. The next slide shows, I like to joke that this is from the medical journal Time Magazine, but this was in Time Magazine, and it's a PET scan. And on the left side, you have a PET scan of a young child who shows different areas of the brain where there is activity going on, and the red and the green and the yellow show that there's activity in that part of that child's brain. On the right side of the slide of the picture is a child who was raised in an orphanage in one of the countries of Europe behind the Iron Curtain. Well, that shows my age, doesn't it? But these children were cared for. They were fed and swaddled and laid down, and then 2 hours later someone would come by and feed and diaper and swaddle them again. So there was none of that send and receive interaction. And what you see is there are large areas of those babies' brains that are not physically lighting up. They did a study where they looked at what they call middle-class toddlers in American families and found that only 5% of them had abnormally high stress hormone levels. But if you looked at these overseas orphanages like the picture on the right, 30% of those toddlers had abnormal hormone stress levels. So these are some things that I think really, for me, give me a picture where I can close my eyes. I can actually see what ACEs are doing. The next slide shows a pyramid, and public health loves pyramid, and you're going to see a pyramid later from Dr. Fink, but this shows that the adverse childhood experiences are the base, which leads to social, emotional, cognitive impairment. Then you adopt adverse behaviors, and we think you begin the cascade of the inflammatory process from those adverse stress hormones that leads to disease, disability, social problems, and even early death. So the next slide is going to talk about our behavioral risk factor survey that the Kentucky Department for Public Health does. This is a survey funded by the CDC since 1984. where you get a telephone call. They call adults ages 18 or older that are not incarcerated, and they ask a series of questions so that we know if someone says that there are 24% of Kentuckians smoke. We didn't call all 4 million of them. We called a statistically significant sampling with all the epidemiological factors to give us a good answer of what's happening in Kentucky. And so besides the basic questions that we've asked every year since 1984, states can add a module of questions. So in 2014, we decided to add these questions on ACEs to find out where Kentucky is. So the next slide shows you, as Dr. Fink referred to earlier, it's divided into two groups, 3 areas about childhood abuse, and then 5 areas on household dysfunction. And those were covered nicely in that slide. So the next 2 slides show you the questions that these people were asked. It's very interesting. If I ask a patient about their life before age 18, not only did they answer you honestly, but they were kind of happy because no one had ever asked them that. Were I to ask them these questions about what was happening to them now, they would be afraid to answer because they would be afraid someone's going to come in and intervene in the situation. Asking people what happened up until you were 18, they're not guarded at giving those answers. So the questions are, and you can read these and they'll be archived later, but ask about depression, suicidal or mental illness in the family, drug abuse, alcohol and illicit problem drugs, illicit drugs, someone serving time in a correctional facility, separation and divorce, physical trauma, especially to the mother. Then the next slide, it says, how often did someone in your home ever hit you or physically harm you? Adult in your home swear or insult you? And then how often did anyone 5 years older or an adult either touch you sexually, try to have you touch them sexually, or force you to have intercourse? So if you look at our results and you put them against other states, you can see that Kentucky has, in the 4 or more ACEs category on the right, 17.5%. That's the highest number of all those states. Now, 17.5 is probably not statistically different than 17%, but it certainly is troublesome to see Kentucky in that category. What we did in the next slide is we actually took the answers to our ACEs scores, and you can see it broken down by ACE scores. We usually have around 8,000 people that answer these questions, and what we found that 40.7% said they had no ACEs, which is wonderful. But the next slide compares the Kentucky data to what the United States looks like. And those red numbers show that by the time you get down to 3 ACEs, we're getting pretty close to the national average. By 4 ACEs, we beat the national average by a small percentage. And by 6 ACEs, we are at 3.0, which is almost double what the national average is for 6 adverse childhood experiences. Again, this is a very troubling trend. The next slide looks very much like what we've already seen. In fact, it's to the nose. We found that 36% of Kentuckians had only 1 ACE, but 64% of Kentuckians had 2 or more ACEs. And I believe the other slide was that 36% of the people had no ACEs. In Kentucky, 36% of the people that had an ACE had at least 1, and 64% of them had 2 or more ACEs. The next slide is a dated slide, and I apologize because I haven't updated it, and that data is available, but it's really not that different. This particular National Survey of Children's Health was when they called parents and said, tell us about your child, and went through the ACEs score. So this is a parent talking about their child. 30% of Kentucky children had an ACE of greater than 2. 1 in 5 of our children had greater than or equal to 2 ACEs, which is very different from the national averages. And then Kentucky children that had 3 or more ACEs was one of the highest rates in the country. So the next series of slides I'm going to show you, I'm going to go through rather quickly. For those of you with a medical background, this is a dose-response curve. So on the left you have 0 ACEs, and the further you go to the right, you have more higher ACE scores, and you're going to see higher response to the particular medical issue that we're looking at. So this first slide shows that children that started smoking before age 14, if you get up to greater than or equal to 5 ACEs, you've got over 20% of these kids will start smoking before age 14. Now if you look, that data is from 1999. That shows how long this data has been being collected, and it's 2018, and many of you are hearing this for the first time. That's why we're doing this webinar, and I applaud Foundation for doing this, because we want everyone to know about this. The next slide is an interesting one to me. On the left it shows the dose-response curve. The higher your ACE score is, the more likely you are to be an alcoholic, and interestingly enough, the more likely you are to marry an alcoholic, because you probably had an alcoholic parent and see this as normal behavior. It's what you knew growing up. The next slide shows you having intercourse before age 15. The middle group shows that you have that you are a female and you're pregnant in your teen years, and then the third set shows that you have fathered a child. You have teen parenting, paternity in your teenage years. The next slide is quite frightening to me every time I see this, but if you look at the far right, if your ACE score is 17 or greater, then your chances of attempting suicide before you're 18 is dramatically higher than at lower ACE scores. Next, we're going to see depression, which again is not very surprising. The darker colored bars are males, and the lighter colored bars are females. Even though the men are not as high as the women, it still has that same dose-response curve that we talked about. And so the next slide just summarizes this. You're 3.9 times more likely to have lung disease if your ACE score is over 4. And then it goes down different medical conditions: heart disease, cancer, diabetes, and even learning and behavioral problems in school, as we're going to learn about a little bit later. Those increase as you have higher ACE scores, and as we heard before, it's going to increase your risk of STDs, broken bones, etc. So now we're going to get to the Kentucky data. This is all Kentucky data. The stuff I showed you before was national. So if you look at current smoking in Kentucky, it doubles if your ACE score is 3 or higher. In the middle, you've got a doubling of binge drinking. Obesity is not a big difference in that one. The next slide shows an increase also in arthritis. You double your chance of having asthma if your ACE score is 3 or higher. COPD is almost doubled, and then you have a tripling of depression. And these are all questions that were asked in Kentucky of Kentucky residents. The next thing we did was we took all of our questions and we did them by ad district. And so you're going to see those 8 areas where the questions are, and I'm going to just real quickly go through these one after the other. Now remember, this was 18 years ago. People answering these questions are 18 years old or older, probably older. So you may be a bit surprised that the highest risk or higher areas are not in our eastern Kentucky, where our lower poverty rates are, where our opioid problem is today, but this is separated or divorced parent by ad district. The next slide shows substance abuse in a household by ad district, very different from where I think we would see that if we ask these children today what their answers would be. Next is verbal abuse in the household. The next slide is you witness domestic violence. Next is mental ill household member. Next, physical abuse in the household. The next is a sexual abuse in the household by ad district. And then last is incarcerated household member. So this just gives you where these people were in their childhood, and certainly gives us a lot to think about. The next slide I wanted to show you, and this is from YRBS, which is a Youth Risk Behavioral Survey that the Department of Education does, and they ask children questions similar to Burfus. One of the questions they ask is, do you have an adult in your life that you can trust or talk to about a serious problem? Among Kentucky high school students, 13.9% said they did not have anyone in their life they could trust. They also asked these kids at the beginning of their survey, are you an A student, a B student, a C, or a D and F student? Of our D and F students, 20.9%, so that's almost 21%, said they did not trust an adult they could talk to, and that also to me is quite chilling. And how much does that have to do because of our adverse childhood experiences? So the next slide shows our babies that we saw at the very beginning. This is not an advertisement for bottled water. This is because I thought this really showed our babies have grown up and they've turned into big people. And how these babies went from their innocent look to where they are now is definitely shaped by what has happened to them. It's very important that we ask people what happened to you, not what's wrong with you. My example is a young woman I saw in my practice. I asked her if she was still a smoker, as I ask everybody. She said yes. And I asked her how old she was when she started smoking, and she said she was 10. So I said, why did you start smoking at age 10? And she said, well, my father really hated the smell of cigarette smoking. And if he came in my room at night and I smelled like smoke, he would leave me alone. And then she looked at me and said, I taught my 8-year-old sister to smoke cigarettes. I was a bad sister, wasn't I? Because she knew the next thing I was going to say were the 32 things that happen to your body when you smoke cigarettes. She'd heard it every year for the 4 years she had been my patient. But what she really heard me say was, you were a terrible sister because these 32 things are going to happen to your sister. She did not understand what I was trying to say was to be helpful in motivating her to stop smoking. She was doing what we would consider a terrible health habit, but yet she was doing it for great reasons. So the next slide tells us that it's easier to build strong children than to repair broken men and women. I added that. I think Frederick Douglass would agree with me at this point. ACEs, Adverse Childhood Experiences, is part of our State Health Improvement Plan. It is part of our State Health Improvement Plan here at the Department for Public Health. We want you to join our ACEs network. Right now, unfortunately, our website is under construction. We're doing some Strengthening Families program and a Youth Thrive framework that we're going to be using, you may hear about later. There's all kinds of work being done on adverse childhood experiences. This is my contact information. As we grow that, we would love you to be a part of that. And a great example of how ACEs can be used out in your community is the Bounce Project. So I'm going to turn it back over to you so you can give us some terrific information that I've been very fascinated with, and think it's a great example of how Kentucky is on the forefront working with adverse childhood experiences.
Thank you, Connie. So the summary, and one way of summarizing some of what Connie was just talking about, or Dr. White was talking about, is that obviously adverse childhood experiences have an impact on all aspects of the child: the brain, the self, the appearance, the emotions, the memory, relationships, learning, and behavior. And if we had a day to do this talk, which we do in training sometimes, we could talk about the different ways that these all manifest themselves in the classroom. But we will get to that in a moment. In case you're wondering as an audience about what the impact does this have on my classroom, here is something from the state of Washington, and it's a nice picture of a classroom with 30 chairs in it, and how many of those chairs would represent kids with either 0 ACEs, of which there were only 6, 1 ACEs, of which there would be 5 out of the 30, 2 ACEs, 3, 4, and 5, and 6. And one of the pieces to remember, there's 2 things to remember in this. One that hasn't been talked about, I think, to this point, is that an individual with 6 or more ACEs typically has a life expectancy of 20 years less than an individual with 0 ACEs. So again, there seems to be a loading factor with the ACEs study. It's also important to note that there are 6 kids in this, or 20% of this population that does not have any ACEs. And what does that mean for the rest of them? And we're going to talk about that as well in just a moment. This is something from Iowa that Dr. White shared with me that I think is also important to keep in mind, because in an Iowa study what they found was that on the average, 5 out of every 30 students in a classroom have a parent in their home with an ACE score of 4 or more. So if we talked about earlier, if you think about the conversation of the impact of having 4 or more ACEs on health outcomes, depression, substance abuse, then what you recognize is that then those children, then the next generation that are in your classroom, have already been subjected to those very ACEs as well. I'd also like you to take a look at these 3 charts. The top chart shows that as ACEs increase, behavioral outcomes in the classroom decrease, so that you have more behavioral problems in the classroom as you have an increase in the number of ACEs. Similarly, this diagram on the bottom left shows that as an individual's ACEs increase, their learning difficulties also increases, and as ACEs in the bottom right-hand corner, the graph shows that as an individual's students' ACEs increase, their attendance decreases. Again, these are all concepts that I suspect as educators we're all very familiar with and concerned about. So what do we do about these situations? And what we do, actually before I get into that, I apologize, I want to review some other quick statistics from SAMHSA that I think are useful. One is that young children exposed to 5 or more significant adversities in their first 3 years are almost twice as likely to have delays in cognitive, language, and emotional development. So as we think back on Dr. White's data that looks at Kentucky, where 1 in 5 of our youth have this situation, it tells you that already in school, by the time a youth comes into school age years, we are dealing with the impact of ACEs and its interference with their ability to optimize their educational opportunities. Earlier, when I showed the statistic about the Washington classroom, I mentioned that roughly 13 out of the 30 kids had 1 to 3 ACEs, and some statistics would say we don't have to worry about that. However, it's important to remember that 35% of children exposed to even a single traumatic event will develop serious problems. So the answer to this is, how do you build resiliency? And that is what the Bounce Coalition is about. And the Bounce Coalition, as I mentioned, has developed trainings that we have done with schools. We've also done with healthcare providers, managed care organizations, out-of-school time providers, and other agencies. And what we are endeavoring is an opportunity to build resiliency, and keeping in mind that trauma doesn't impact everyone the same way, but that we're going to follow what we would call resiliency building principles, and we train on those principles. So just to review what those principles are like, is the opportunity to always empower. One phrase that's often used is that it's the idea that we are giving youth a voice and a choice whenever possible. That doesn't mean that a youth should be allowed to stand on top of a desk in the classroom, but there are other opportunities that we can empower our youth so that maybe we can keep them from climbing up on that desk in the classroom. There's also the idea of unconditional positive regard, that we are talking to a youth based on who they are, not what their behavior is. We also want to be setting clear expectations and high expectations. It's often thought, as you talk about building resiliency, building principles in an environment that is a trauma-informed environment, staff sometimes think that you're talking about not holding youth accountable, and that's the farthest from the truth. That actually youth with histories of trauma, if they are not held accountable, regress to the lowest expectations. So like all other folks, and it's true of our staff as well, we have to maintain those expectations. There's also the hope to check assumptions, and this is the idea that we want to be thinking about a youth's behaviors as an attempt to gain something. It's not always, while the overt behavior is disruption, there is often something within that behavior that is either self-preserving or sometimes even taking care of another, and we want to keep that in mind. Building relationships become a key to resiliency building. For 2 reasons, really. One is that when you are intervening, it is always easier to intervene in the context of a relationship than it is without one. And the other is that as you get to know your kids, you hopefully are able to anticipate some of those triggers that create sort of the traumatic response. And then always look for ideas and ways to help kids feel helpful, feel that they can participate. It's important, I think, also to distinguish what a trauma-informed system is and what it isn't as we then begin to talk about systemic interventions. Trauma-informed system, what it isn't is an individual approach to a youth. It's actually about a system recognizing the impact of trauma, being sensitive to trauma-related issues, and utilizing that understanding to avoid re-traumatization. By definition, a trauma-informed system has to be unique and flexible. So one of the important pieces is that we often meet with the leadership of the school to talk about what programming they have and what programming is missing so that we can blend into what they already have, because a lot of this information is not new to faculty and to administrative leadership, but it helps to consult and to look for avenues to help them build on their strengths and buttress their weaknesses. It's a healing process, and as I mentioned earlier, it views symptoms and behaviors as adaptive and not pathological. And by all means, a trauma-informed system is always looking for opportunities to avoid re-traumatization. I think it would be important as we talk about the Balance Coalition to give credit to help the information out of the Harvard Trauma and Learning Policy Institute, an initiative, which is, they have 2 editions, the Helping Traumatized Children Learn, which is where some of our research was based on. Let's talk about the bounce model itself and the implementation of that in a school. Similar to many school approaches, we use a 3-tiered support approach to the school. The first tier is professional development, and that's with classified and certified staff both. We have classroom guidance lessons that we utilize, and I'll talk about those briefly in a moment. And then we have parent education and programming, as well as a presence in the coordinated school health programming so that we can begin to talk about specific kids if necessary. The Tier 2 supports are classroom and small group interventions for youth who school officials have identified as at-risk kids, that these are kids who appear to be in need of some additional coping or social skills group, and it's a time-limited group that typically is conducted by the counselor, by the school counselor, so that it does not interfere with academic time, and is an opportunity for the kids to develop that relationship with somebody within the school. The third tier is for youth that are continuing to demonstrate and display behaviors and mental health concerns within the classroom, and those are referred out for treatment. The Balance Coalition actually does not provide treatment, but we certainly coordinate with community partners and work with community partners to help facilitate some of the communication that's important between a community-based provider and the school. So there really are some key areas in developing a traumatized school. As I mentioned, the involvement of leadership is key. Leadership has got to believe in and understand the importance of a trauma-informed environment and resiliency building to help with those youth. We work a lot with professional development. As I mentioned, we have training for both certified and classified staff. In a district such as Jefferson County, where we have a large number of youth who are transported by bus, we also have training that is specific for bus drivers. That's an important aspect because if you think about it, those are often the first folks who have contact with that kid during the day. They often see things that even the assistant principals and staff within the school don't see in terms of how a youth presents before the school day even starts. And we talk a lot about how to manage safety on a bus and how to manage behavior on a bus and how to be thinking about those aspects of it. We work with the school on accessing resources and services. As I mentioned, sometimes that's coordinating with outside providers. Sometimes that's talking through what resources may be available within the school district itself in terms of classroom management techniques and things of that nature. We look at academic and non-academic strategies. We sometimes bring in outside experts who may have some expertise in a particular need for that school. We recommend a look at the policies and procedures and protocols, how trauma-informed are signs in the school. Do signs in the school remind kids what not to do, which is sort of a negative approach, or do they remind kids what to do? That talking in an inside voice is a lot different than no talking in a hallway or things of that nature. And of course, a school is never stronger than it is when it can collaborate with its family. So certainly one aspect of the balanced curriculum is to have meetings with families, trainings in the evenings if necessary or during lunch so that families can participate as well. The three primary goals of the all-staff training are to increase the knowledge and awareness of trauma, to identify the effects of trauma, including the trauma lens. And Dr. White talked to this a little bit when she mentioned the idea of looking at a youth in terms of what happened to that youth as opposed to what's wrong with that youth. That as we focus on what happened to that youth, again, it's not about excusing a behavior, but it's about putting that behavior in context. The other aspect I should mention about the trauma lens is very important, which is that if you think about the idea that 64%, that we know from the ACEs study, that 64% of folks have had at least one traumatic experience as a youth. And then we come to adulthood, the providers in our educational system and really in all of our systems of care fall into that, are likely to fall into that 64%. So that the notions of self-care and teamwork become more important because there are situations where it'll be important that we support each other and recognize the limitations that we all have and that certain kids will impact us more than others. And so it's very important that we keep in mind concepts of self-care. And so there's some training that occurs with that as well and some exercises such as mindfulness and progressive relaxation that not only do we recommend that teachers use with kids, but also that teachers use with themselves. And we also then have some specific classroom intervention strategies that we recommend using, and which also include thinking about language-based approaches, both with parents and caregivers as well, not just with the kids. And an example of this is that I think it's really important to talk about adverse childhood experiences with parents and not specifically with trauma. Parents sometimes can become a little bit concerned about what an agenda is if all they hear about is trauma, 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 because sometimes schools get a bad reputation about what it is that their focus is on. And I think that it's important that parents are aware that what we're looking at is ways to help their kid who is struggling. Probably if they're struggling at school, they're also probably struggling in some ways at home as well. And so it's important for them to help us help them. So there's some language suggestions that we use and some approaches that we talk through with staff about that as well, and are willing to talk with some of the families also. As I mentioned, there's classroom discussions that occur as well. There's a book for elementary school students actually that we use and a lesson plan for the counselor to use. And part of this, and the reason that I emphasize that it's the counselor, is that the bounce model itself in the school program is really designed to be a self-sustaining, inexpensive model so that the school can maintain and internalize that program and continue on well after the resources are gone, that the resources really are within the school and how to access those resources. I already mentioned the lunch bunch for at-risk youth and then the referrals that occur as well. So let's talk a little bit about how we know whether or not the bounce program works. And one piece that I realized that I have not mentioned so far that I think is a really critical piece about the overall training is that it's important that when we do this training that we always inform educators that this training is not about helping them diagnose the existence of trauma, because that's not what their job is. Their job is to recognize that the trauma has an impact on their teaching opportunities and their ability to maximize their teaching, and that they want to be aware of those signs, not to diagnose it, but to understand it and to be able to work through it. And an important aspect of that is that one of the pieces I often ask is if educators in the room define themselves as educators, and as you can imagine, right, they all raised their hand, yes, they did. Now the fact is that depending on how many years they've been a teacher, most teachers at this point, unless they have less than probably 5 to 6 years experience, really have not had a lot of experience in classroom management specifically related to trauma. Not many of our universities are training in that area. And if you ask teachers, though, if they see themselves as healers, then none of them raise their hand. And part of the overall message of the Bounce training is that you really can't be a teacher. You can't be an educator unless you're also a healer. That we're all healers in some ways. And so that is a piece that's important to keep in mind. So let me jump in, though, to some of our evaluation aspects that talk about how it works. And before I jump into that, though, I want to acknowledge a question that came up on the board, which is that is there an informed peer-to-peer support component to your model of care? And I will tell you that is a great concept, but not one that this particular model has utilized. So if you, in terms of the measures, if you remember, the pieces that we looked at were student attendance, teacher retention, out-of-school suspensions, academic achievement, school climate, parent engagement, and staff's perceptions of their own skill set. And our hope was to have some positive movement on any or all of these factors. And what you'll find is that really, with the exception, I'll cut to the chase here, which is that with the exception of school attendance, we actually have had a tremendous impact. So this first diagram shows, at the top it shows attendance, and it shows our Bounce school for 3 years relative to a control school, which was similar in size and socioeconomic status, free and reduced lunches, things of that nature, and to the overall district. And attendance, as I already hinted, really it did go up in the Bounce school, but it went up by 0.2%, so it was not a significant finding by any means. Now, if you look at suspensions, while suspensions in the Bounce school did go up over the 3 years, they went up much less than was relative to the control school or than the district school. Teacher retention went up significantly, while in the control school it decreased and did not go up nearly as much in the overall district. So certainly of the 3 items in this particular graph, or this particular bar chart, it shows you that while attendance did not improve relative to both the control school and the district, the Bounce school improved in both teacher retention and suspensions. We also use the comprehensive school surveys that Jefferson County Public School uses to look at some of the data about the school climate. And in particular, we were focused on how, research on resiliency also shows that resiliency will improve if a youth has one important person in their life. And there are some activities, again, in the classroom curriculum that we use to help a youth identify who that person may be. And certainly in the end of the research, the data shows that in the Bounce school, the there was an increase overall relative to the start of the study in the number of youth who reported having a teacher that cares about them. And I will point out as well that while the Bounce School improved in that category, the control school and the district both decreased. Similarly, the Bounce program, in terms of a caring and supporting environment, while the overall decreased relative to where it started, again, the decrease was less than was identified in either the district or the control school. Feeling safe at school, and this is a school that is not in a terribly safe neighborhood. The Bounce School improved. And the same was true from the student perspective and the parent perspective. This was, for some of us, one of the most surprising findings, because educational improvement is something that you often don't see very quickly, but the Bounce School in its state assessment testing improved far greater than either the control school or the elementary school, particularly in math, and its improvement was a little bit better than the control school, and certainly better than the district in reading growth. And while I'll point out that while this was a measure of growth, not overall score. Finally, we talked about the goal was to also improve the skill sets of staff. So in talking with staff and in surveying staff, what we found is that from the beginning of the survey, when we the pretest before Bounce started, 64% of staff reported, actually I should say 70% of staff reported that they had either no skill set at all, a very limited skill set in working with kids who have experienced traumatic events. By 2 years later, surveying the same staff, we had cut that in half, and that over 60% had said they had either adequate or extensive skills in dealing with youth. So what are the walkaway messages that I would like to you all to hear? One is that adverse childhood experiences are prevalent, highly prevalent among students that we serve, and have a long-term damaging consequences for mental and physical health. So intervention becomes important because there's even short-term evidence that even ACEs have a short-term impact on a youth's ability to optimize their educational opportunities. So trauma-informed approaches within a school can help mitigate those. And the Bounce Coalition has developed an affordable and sustainable model for implementing these practices within the school environment. And we also have a Train the Trainers model. And in fact, later this month, we are doing a Train the Trainers model, a Train the Trainers training, although that's August 30th. That is not specific to the school population. That is with other systems of care and other individuals that come in contact with youth. I want to again thank you all for the time. I'm going to, while I point out what my email address is for further questions, I will also remind you that this is my email address for my full-time work, but that in addition I am the co-chair of the Bounce Coalition, and certainly we have a Bounce website but it would be best to contact me directly on this email. And if you just put in the title that you're referring to Bounce, it'll help me make sure that the question, if it's not one that I can answer directly, one of the other members, I can get it to one of the other members of our coalition very quickly. I also have a page of resources on this spreadsheet that include the Bounce website, although our Bounce website, similar to what Dr. White said about her website, Bounce website is currently under renovation. So with that having been said, I think that I am about out of time, and I thank you all for your time, and I will turn this back over to Rochelle to finish up.
Thanks so much. I want to say thank you so much to our speakers. Their expertise and data that they shared with us has been Very important to start this conversation, to set us on some basic definitions of ACEs and to see with the Balance Coalition already some early results. Very exciting for me. Thank you, Dr. David Fink, Euspiritus and Balance Coalition, and Dr. Connie White from the Cabinet for Health and Family Services. And for everyone on the call, you heard them invite you to get in contact with them to get involved with what's happening in ACEs in Kentucky. For me, I want to thank you for joining us today on this Foundation for a Healthy Kentucky webinar, part of the Health for a Change training series. The slide I have up is our social media. I tweet out of Kentucky Health Facts with the data websites. All of our information, including the Health for a Change training page, is under the Events tab at the Foundation for Healthy Kentucky's website, healthy-ky.org. Also there you can sign up to join the Foundation e-newsletter where you get announcements of special events that are coming up, like the Health for a Change training series. Finally, everyone, please, I'll send out a post-event survey this afternoon. Your input to me is very important. I want to know what you thought about the webinar. I would love to hear suggestions about other trainings that you think would be useful. As I mentioned, I coordinate this training series for the Foundation for a Healthy Kentucky. Since 2011, this training series has reached people just like yourselves in all 120 of Kentucky's counties. So I thank you so much for joining us today. We welcome your questions via email, and I appreciate your being here today. Have a great afternoon.